This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME through MyCares and Michigan State University. The link for the CME is in the show notes below. This week is really kind of exciting because we're going to be talking about everyone's favorite, kind of the new statin, semaglutide. So I'm excited to hear about this article for alcohol use disorder that you're going to present, Sonya. How have you been doing?
I'm doing great, and I'm excited to share this article because I'm just coming off of an hour of discussing semaglutide for diabetes with the residents. So if I get confused, forgive me.
You're forgiven. What's new this week for you?
So I just, back to school is right around the corner. I'm not sure when this episode will be released, but school will be just starting. And, last fall we talked about those vapes that look like school supplies and were targeted at kids. So
the highlighters.
Now, I know that. Oh, yeah. The highlighters that, that were actually vapes. And so now the FTC just had to send out some cease and desist letters to companies that are packaging Delta 8 THC products that look like candy and that appeal to children. They're calling out the companies on deceptive marketing. And it just made me think about this huge surge in pediatric cannabis poisonings also that's going on, mostly due to edibles that look appealing to children. There was an article in the New York Times about that, and a quote from that article. It said there were more than 7,000 reported cases of accidental ingestion by children 5 and under between 2017 and 2021. So 7,000 cases in that 4-year period. And then the cases rose 1,375% over that 4-year period, the study found. And in virtually all of them, the edibles were ingested in a residential setting, meaning like at home. So John, when you have patients who are using marijuana edibles or on medical marijuana, do you counsel them about keeping them away from children?
It's interesting. I think it just kind of reflects the patient population that I take care of that kind of use cannabis for one reason or another. But I think most of my patients end up using kind of dry leaf because of cost. I know kind of like the edibles, the tinctures are significantly more expensive. That's probably something should be incorporated. My brother lives in Denver, Colorado, and so there it's legal for recreational purposes, and it's kind of a interesting, somewhat surprising where you see people kind of openly kind of using marijuana on the street, but also kind of like openly consuming edibles. And it's interesting. I've noticed when we're out to restaurants or going to places that a lot of them look very similar to what we would think of as kind of like our commercially available like candies. So they're made to look like the same packaging as like Skittles, for example, but the name is different and the colors are the same though. Where they have ones look like Hershey bars, which is kind of here from South Central PA. But it's, if you read the fine print or the label, you kind of on closer examination, it's not a Hershey bar. So I think that sometimes they really, as like a marketing ploy, they make these look a little bit too identical. Like it does seem like something I'm sure at some point they're going to have to kind of, I hate to say regulate, but it seems like that probably shouldn't be the case. That should be indiscernible.
Yeah, I mean, I think that's what the FTC doesn't like. Like you can have a package that says, THC Delta 8 edible on it, but it can't be like Hershey in big letters with, THC written really small and made to look like a chocolate bar. So, yeah, it just made me think I should, if I do have patients who I know use medical marijuana and use edibles, that I remind them to keep it safe like any other medication away from kids. It's just particularly appealing. I mean, I know kids get into medication all the time, but the child is probably less likely to dig through the medicine cabinet and take, a bunch of Advil compared to like the bag of what looks like candy sitting on the counter. So
one time I was a science fair judge, and this is like a totally sidebar, but I was a science fair judge, and one of the coolest projects I ever saw, and this was actually like an 8th grade science fair project, and the child took medications that were different colors, and then they had children under age 7 kind of identify candy, and they put M&Ms and other candies in the dish, and actually, the colored pills, they couldn't kind of decipher that wasn't candy. So it's similar with that. And I think that we've gotten better about kind of like with marketing our medications, kind of making them look kind of more distinct. But I think they're going to have to do something similar for this eventually. Or there's going to be continued exponential rise in these kind of accidental poisonings.
Yeah. Well, heck, when that happens, we will let everybody know. John, is there anything you've been thinking about in addiction medicine news this week?
I read this article from LA Times, and it was an opinion piece, and it was actually, you would think I would kind of agree with everything in it, but I actually kind of don't know if I feel that strongly. I do agree. It's called "Surgeons Give Patients Too Many Opioids: A Few Simple Steps That Could Curb Excess Prescribing." And I think kind of the article kind of started with a basis thinking that we prescribe too many kind of post-operative opioid prescriptions. And I will say, like, in full transparency, I would say the data probably says at one point in time, I think that was probably pretty prominent. Um, they talk about data from 2021 saying that kind of 45 people per day die of basically overdose involving prescription opioids. 1 in 5 all opioid deaths at this point involve some sort of prescription opioid as well. So still kind of not the majority, but a substantial amount. And basically, kind of the assertion from the article was that, large post-operative supplies end up being given to patients which aren't used, and basically they end up circulating. So in grandma's medicine cabinet, they're given to others. And I don't know if this is kind of just a reflection of, I guess, the market that we kind of operate in. I think our surgeons are pretty tight with the opioids at this point, kind of 3-day supplies for kind of most kind of routine procedures. But they kind of made it sound like there's a lot more going on, and probably it is in other markets. Interestingly, they did talk about kind of methods and studies that have previously been shown to kind of decrease prescribing habits. And they talked about kind of initially kind of these kind of like non-targeted feedback where they kind of gave information to a group of surgeons or a department of surgeons about kind of best practices for opioid prescribing. It was actually kind of relatively ineffective, which I think mirrors what we do with other things. And they talked about how actually kind of programs and studies where they've given targeted feedback, kind of letting a surgeon know that, like, you prescribe, you're in the 50th percentile for opioid prescribing, or you're in the 80th percentile for opioid prescribing, actually did kind of mitigate prescriptions by, in some cases, around 25%, they were talking about. So I think it's an interesting idea. I don't know. What do you think? Do you think that we're still prescribing too many opioids after surgery?
I can't tell. My son had a relatively minor surgery last year, and I ended up having to dispose of a large bottle of Percocet that was unused. So apparently, yeah. But, my surgical colleagues I see now, most patients are getting pretty limited opioids in our health system. But, St. Max's has made a real concerted effort to standardize and control, post-op opioid prescribing. So I don't know how we would compare to other health systems where maybe there's not as much attention being paid to this issue. I feel like we've really done a great job looking at it. And I don't see a lot of what I would view as excessive opioid prescribing post-op.
I haven't really seen it lately from any of my patients, and even from the surrounding kind of surgical centers. Yeah, I do think there's been a big shift here. I think I can remember kind of one of our really respected and excellent surgeon at our institution got up in front of everyone and was talking about when we were reforming kind of opioid prescription about kind of standard practices, like, 10 years ago, 60 oxycodone, 10 milligrams after kind of a routine discectomy was kind of standard of care that he was trained in, and that was his practice, and how now it's down to like 12 or 15. And, that's a pretty big shift. And also, I gotta say, that's gonna be hard to get up there and throw yourself out there to be like, this was my practice. I recognize it wasn't ideal. This is my new practice. I thought that was pretty courageous.
Yeah, I think we've all, the opioid epidemic, especially early on when it became clear what our role was really sobering for a lot of doctors. We just saw this incredible amount of harm that we were causing, either personally or as a profession. And I'm glad a lot of people sort of stood up and said, I've been doing this wrong. I need to change. And it was very hard on a lot of patients. But
I do think, though, patients don't fit into a square box, right? There's no one size fit all. I do think that there's probably a couple casualties along the way with this, right? I do think that there's time where probably pain still isn't adequately controlled. And surgeons are in the OR, right? So that's where they live. And so I don't think they always have time to reassess and re-prescribe if there's a indication where they would warrant additional pain medication. And I think a lot of times I do see that kind of coming our way in primary care, where we're kind of playing cleanup for that. Although that's part of the job, right?
Right. Yes. Playing cleanup for other people.
So I prefer the term last line of defense, not cleanup. But yeah, I guess we're kind of catching anything that slips through the cracks.
Now I'm having images of the guy who goes last in the parade with the big shovel after the horses.
I'm younger in my career. I'm not that pessimistic yet. I'm still pretty optimistic about the future.
Well, I'm optimistic about the future too. And on that note, should we talk about semaglutide for alcohol use disorder?
Yeah, let's talk about it.
I mean, there is just so much about semaglutide. There's new articles coming out every single week about the GLP-1 receptor agonists. And I'm super excited about these articles using it for addiction. So, a little bit of background. This article is titled Association of Semaglutide with Incidence and Recurrence of Alcohol Use Disorder in Real-World Populations. And it was published in Nature Communication this year, just a few months ago. So everybody loves semaglutide, the GLP-1 agonists. There are 10 different GLP-1 receptor agonists or GLP-1/GIP agonist medications on the market. And the two ones that are most commonly prescribed are semaglutide, which has brand name Ozempic or Wegovy, and tirzepatide, which has brand name Mounjaro or what's its other name?
Zepbound.
Zepbound. Yes, I can't believe I forgot that. So at this point, John, if you had to guess, what percent of Americans are taking one of these medications right now?
I'm going to guess 6%.
Oh, you're high. 4% of Americans are currently taking a GLP-1 or agonist. 13% of Americans have tried to take them or taken them at one point or another, but only 4% are actually taking them today. But that's still a lot. 4% of Americans are taking these medications. So they're very common. Alcohol use disorder is another thing that's very common. About 10.6% of Americans aged 12 and up had alcohol use disorder in 2021, and it's responsible for more than 80,000 annual deaths in the U.S. It's among the top 10 conditions associated with the largest global burden of disease worldwide. And therapies for alcohol use disorder are helpful for some people, but they're really not universally effective. Anyone who tries to treat alcohol use disorder just knows that these medicines help, but they're not magic bullets. I tell my patients this medication is not going to come and just slap the drink out of your hand. It's going to help you quit alcohol. It'll make it easier, but it's not going to force you to stop drinking. Even the most effective first-line treatment, which is IM naltrexone, it just reduces heavy drinking days by 1 to 5 a month on average, depending on the study. It might reduce alcohol consumption overall by only a small amount on average. So, this isn't to say that these current therapies are useless or shouldn't be used, but they aren't as effective as I would like. So the possibility of a new medication for alcohol use disorder is really, really exciting. The next thing I wanted to share is that it's very plausible that GLP-1 agonists will reduce alcohol consumption, although the exact mechanism is still unknown. We do know that these GLP-1 receptors are present throughout the ventral tegmental area and the nucleus accumbens, where all those dopamine reward pathways are located. They're also in the habenula, the area that's involved in negative reinforcement. And the GLP-1 receptor agonists also cause delayed gastric emptying, and so that would slow absorption of alcohol from the GI tract, which reduces the reward and increases the gastric metabolism into acetaldehyde, making the alcohol just less pleasant. So those are two potential physiologic mechanisms. We also know that semaglutide reduces drinking in rodents, so we've seen it in rats. It binds to the nucleus accumbens and attenuates the alcohol-induced dopamine surge. We've also seen anecdotally in humans that semaglutide reduces alcohol use in people who are taking it for diabetes and obesity, although again, it's a little more kind of anecdotal. We have one small clinical trial that did show reduced alcohol use with exenatide, another GLP-1 receptor agonist, in a subgroup of patients who were in a larger trial of that medication for obesity. So there's a bunch of reasons to think that semaglutide would help with alcohol use disorder, and this is a study to try to look more deeply into that question. So John, I'm sure you have experience using semaglutide. Have you seen any connection between that and patients' drinking habits?
Anecdotally, patients have told me that they feel like they drink less when they take these medications. And this was really kind of solicited questions that people be like, since I've been on this medication, I've lost weight, and I used to drink like, 2 bourbons. Now I will drink one, and like not like my heavier drinkers, but these are like my moderate drinkers. And so I've heard that a lot. I've actually heard that from some physicians that have taken these, that they said they'd noticed that they drank less, even casually drinking when they've been on these meds. So certainly very anecdotal, but it seems like that seems to at least be the rumor and what I'm hearing.
Yeah, I've seen that too, but I don't know how to sort it out from just eating and drinking less in general once you're on these medications. Like people also really don't tolerate carbs as well. So like beer is harder to tolerate. People also don't drink sweet drinks so much when they're taking these medications. All those become hard to digest and the desire for them goes way down. So I haven't had a sense of whether it's specific to alcohol or just the fact that you're taking in a lot less of every kind of food and drink. So, clinical question. This was a nationwide, multi-center, retrospective cohort study. It had almost 700,000 patients in it, and it used an EMR database, electronic medical record database, to assess the association of semaglutide with the incidence of alcohol use disorder in people with obesity, comparing it to people taking other weight loss medications. So basically, these are all people taking weight loss medications, some semaglutide and some other medications. And they saw if there was an association with developing or having a recurrence of alcohol use disorder with the semaglutide. They did a propensity score matching to create similar groups who differed just in the weight loss medication. And the trial also looked at several other subgroups of patients, so people with diabetes, with and without obesity, as well as subgroups divided by age, by sex, by race, and even a small subgroup of patients who had a prior diagnosis of alcohol use disorder to see if the semaglutide reduced the rate of recurrence. So just a bunch of different subgroups to see if semaglutide was associated with alcohol use disorder. The study included people who were in this TriNetX analytics database. It contains the EHR data of 105.3 million patients from large academic medical centers throughout the USA and all 50 states. So huge database. They looked for patients who had obesity, no prior history of alcohol use disorder, have been prescribed semaglutide or another anti-obesity medication for the first time. Then they also looked at two other groups, people with obesity and pre-existing alcohol use disorder, and people with obesity who were prescribed semaglutide for diabetes prior to it being FDA approved for weight loss. The only concern about this second group, the people who prescribed semaglutide for diabetes, is that the weight loss doses are quite a bit higher than the diabetes doses. So this group may not have been given the medication at the dose that would provide the most benefit as far as alcohol use disorder goes. They excluded people who had a history of bariatric surgery. And in terms of demographics, the patients in this study without alcohol use disorder, the average age was 51. 65% were female, 67% were white, 16% were Black, 56% had severe obesity, 33% had diabetes, and 36% had depression. 15% smoked tobacco, and tons had other comorbidities, 71% hypertension, 46% high cholesterol. And I just threw in here 23% were on gabapentin, since I know you and I have talked some about the gabapentinoids and their prevalence in the past. I also thought it was interesting because gabapentin is a medication used relatively frequently for helping people with alcohol withdrawal management or alcohol use disorder. So basically, bottom line, this is a middle-aged population with a lot of medical comorbidities. In the smaller subgroup of people with alcohol use disorder, again, a lot of comorbidities, even worse than the other groups. So 48% had diabetes, 60% had severe obesity, 58% had depression, 45% smoked tobacco, 83% had high blood pressure, 60% had high cholesterol, and 40% of them were on gabapentin, just throwing that in there. So they had even more health problems in the group without the alcohol use disorder. The exposure was semaglutide prescribed for the first time. The comparison was other weight loss medications like naltrexone, topiramate, bupropion, orlistat, or phentermine. And the outcome was the development or the recurrence of alcohol use disorder as documented in the EHR with a diagnosis code. All participants were followed for 12 months from the index event, which was the initial prescription. Although they did continue to follow people, everyone's followed at least 12 months, and some of the earlier enrollees were followed for up to 3 years. So just to summarize the clinical question, again, these are people getting semaglutide or other medication for obesity. They have obesity. They may have gotten it for diabetes, but they still had obesity. And you saw whether they developed alcohol use disorder more if they got semaglutide versus other medication for weight loss. So, John, what do you think of the clinical question?
I mean, I think it's something everyone's asking now about kind of how does this medication modulate? Certainly kind of the way they're going about trying to answer this question seems a little distant, but certainly very relevant.
Yeah. Yeah. So, in terms of validity, I think this was a valid trial. Some of the strengths include the very large sample size, so greater than 80,000 patients in the matched cohorts. The association between semaglutide and improvement in alcohol use disorder is very plausible, as I talked about earlier. The semaglutide cohort was a little different than the other weight loss medication cohort. So they were older, had more severe obesity, more obesity-related diseases. But they tried to do a good sort of propensity score matching to create two similar groups using a long list of covariates that people can look at in the paper that included all sort of socioeconomic determinants of health, like housing and family support, lifestyle factors like tobacco use, and medical diagnoses. So they did their best to kind of account for those differences between the people who got semaglutide and people who got the other medicine. Also, the different subgroups were studied in non-overlapping time periods. Since initially semaglutide was only approved for diabetes, so the initial people in the study all had diabetes, and the weight loss effects were technically incidental. The subgroups were pre-specified. I thought the follow-up was long enough, given the large size of the study. And I think funding was unlikely to cause bias. It was funded by the National Institute on Alcohol Abuse and Alcoholism and the National Institute of Aging and the National Cancer Institute. So it had a lot of strengths. There were some limitations, of course. The first is that the group of patients with baseline alcohol use disorder was relatively small, only 4,254. Again, and it was a retrospective observational study, so there's a risk for unmeasured confounders, reverse causality, and self-selection. The other thing is that this looked at prescriptions for semaglutide, but as you and I both know, getting a prescription for semaglutide does not mean you got the semaglutide injection because it's not covered by your insurance and it's impossible to find and there's manufacturing shortages. So I'm not sure that everyone who's prescribed semaglutide actually took semaglutide. And of those who took it, many may not have achieved the target dose for weight loss of 2.4 milligrams. So I think that's a limitation. I'm probably batting like 50% of people who I prescribe it to who actually get it.
I think I'm around there too.
The other thing is that the outcomes are not exactly clinical on an individual patient level compared to other studies of alcohol use disorder. So often our studies look at drinks consumed or, alcohol-related adverse outcomes like incarcerations or liver disease, cardiovascular disease, heavy drinking days, all these sort of very patient-centered outcomes. The outcome in this study was, is there a diagnosis of alcohol use disorder in the electronic medical record? So it's not that it's terrible, it's just that it's not clear exactly what that means, and what the implication is of having that diagnosis appear after you start semaglutide. It's not clear, we don't know for sure that it means you're drinking more or less alcohol. Maybe doctors screen for alcohol use disorder prior to starting naltrexone for weight loss so they could counsel patients about the effects of naltrexone on alcohol use. That, just an example I thought of. And finally, it wasn't clear what dose of semaglutide would be best for treatment of alcohol use disorder. So higher doses may be more effective, but that wasn't really studied in this trial. So John, do you think that this was a valid trial?
I think it's valid. I think it's a good trial to kind of get an association here. I certainly don't know if, just because of the limitations of how this is obtained and kind of how they kind of worked about the association, I don't know if I would say that this is a design that I would change my practice patterns off of the results of.
Well, right. And we're in the space thinking how to treat alcohol use disorder, but the bulk of the people in the study didn't have alcohol use disorder. It wasn't treating alcohol use disorder. That was only in a very small subset.
Yeah.
So comparing semaglutide to the non-GLP-1 receptor agonist medication, semaglutide was associated with significantly lower risk of incident alcohol use disorder with a hazard ratio of 0.5. So the semaglutide group, 0.37% were diagnosed with alcohol use disorder, and the other medicines group, 0.73% were diagnosed with alcohol use disorder. So almost twice the number, although overall it was low incidence. And this was consistent in all the pre-specified subgroups across gender, age group, and race. Also seen in patients with diabetes and without diabetes. When you compared it to naltrexone or topiramate, semaglutide was definitely associated with significantly lower risk of incident alcohol use disorder with a hazard ratio of 0.044, which was also consistent across gender, age group, and race in patients with and without diabetes primarily. So basically, the semaglutide, if you got semaglutide, you were half as likely to develop alcohol use disorder in the following year. In patients who already had a diagnosis of alcohol use disorder, compared to the other weight loss medications, semaglutide was associated with significantly lower risk of recurrence of that alcohol use disorder, hazard ratio 0.44. So 22.6% had alcohol use disorder recurrence after semaglutide, and 43% had alcohol use disorder recurrence after any other weight loss medication. Again, this was consistent across all subgroups, gender, age, race, patients with and without diabetes. So basically, no matter how you looked at it, semaglutide was associated with a significantly lower risk of alcohol use disorder. I put these findings in a little table, and I will put them on social media if people want to see the results organized in a table. And there were some cool charts in the paper as well if anybody wants to see it. But basically, in every single subgroup that they looked at, semaglutide was associated with less alcohol use disorder after they started it. So that's the main result of this study. And they're low. The incidence is low. It's not a ton of people, but it's a pretty dramatic finding. So will the results help me in patient care? I think so, maybe. My patients definitely want to take semaglutide for obesity. There's often overlap with alcohol use disorder and obesity. Semaglutide is well tolerated, and I do prescribe it quite a lot in my setting. I'm just not sure of the clinical relevance of the outcome since this was observational data from a large electronic medical record database, but the size of the effect to me is very compelling. So I think in summary, I'm not ready to use semaglutide as a treatment for alcohol use disorder alone, also not likely to be covered for alcohol use disorder, but I'm more than happy to tell patients that they might get reduced alcohol use as a happy side effect of the medication. And I definitely will suggest it as first-line weight loss medication for patients with diabetes or obesity if they also have alcohol use disorder. I don't think I would be above if someone had obesity and alcohol use disorder and asked me how to help with the drinking. I would say, well, let's try semaglutide, for weight loss, and that might help with the alcohol. But I don't think I would use it as my primary treatment without another indication. John, do you think you'll use it for treatment of alcohol use disorder?
I mean, I'm not going to use it for treatment of alcohol use disorder, mostly because it's limitations. It's not approved yet. I can't even get it covered for the indications I wanted to get covered for. It is an interesting medication for a person. Like if I have a patient now that, has alcohol use disorder or concerns for it and wants this, it would make me feel very compelled to consider this as a weight loss option, although it's kind of my go-to as is. It's interesting, the surge of this for alcohol use disorder, because I feel like early on, everyone was worried about everyone getting pancreatitis. And I think we actually kind of actively avoided these medications in patients where we thought they were at risk of pancreatitis, which was this group that kind of seems to benefit. So I think it kind of at least makes it feel like that, we should consider using this for this group if we have another indication. And maybe if more research comes up, that this will be a treatment in our arsenal for alcohol use. Which would be nice because, as we've stated, we've got a small amount of medications in this armory and they only work okay. I mean, they're all right.
Right. They're all right. But I mean, I just can't say the number of patients I've had who start the medicines and then they come back and see me in a few weeks and they say, well, I don't know, it's not working. I'm still drinking.
Problem with that, and this is a whole different thing, it's expectations, right? I think, if you think this is the buprenorphine of alcohol, it's not, right? I tell people you have to be honest with yourself. Like, how much are you drinking now? And then let's kind of look in a month, how much are you drinking then? And I think you'll see that people drink less. It's still more than they probably should in most cases. And their number of binge days decrease, but it's not this kind of pandia I think people are looking for.
Right. Although I have seen it be the buprenorphine of sugar. I have a bunch of patients who start on semaglutide and just don't want to eat any sugar anymore. They're just done.
I was talking about naltrexone.
Oh, so that definitely does not, make people
I was about
not
to say,
want
you're
to eat
using
any
that for sugar? Well, I'm like, I'm missing something.
Treating diabetes with naltrexone. No. I don't use a ton of naltrexone for anything other than alcohol use disorder.
Yeah. Okay. Well, I appreciate that. Was a really interesting article. I think it's going to be, we're going to hear more about this, right? This is coming. Semaglutide is the new statin. We're all going to be on statins, semaglutide, and beta blockers when all is said and done.
We got to find like a long-acting injectable statin, and then we can mix it with the semaglutide, and you can just get it all like once a month. That's what I want.
Maybe I'll get them people to take their statins then.
Exactly.
So a little bit here, we did get some talk back from a previous episode. We even got more new comments about episode 20 about using naltrexone for alcohol use disorder. Dr. David Sirota wrote to us and he pointed us towards another podcast about using naltrexone for alcohol use disorder from a patient's perspective. The podcast is called Reflector, and it's a documentary style podcast. The episode profiled a writer and her journey to find treatment for alcohol use disorder. It was a really great profile of using targeted naltrexone. The episode was called The Sea Change, and we'll put a link in the show notes.
Yeah, I listened to that. It was really good. I like hearing, patient perspective sometimes because it can teach you so much about how to use a medication more than any sort of handout from the, manufacturer.
I recently listened to it. Have you ever seen TED Talks for kind of like leadership development? Well, I was like listening to one for a course I'm doing, and then it kind of automatically goes to the next episode. And the next episode was it was targeted naltrexone, and it was a woman telling us her experience in recovery with kind of the Sinclair method and how great this worked for her. So it's interesting. It's definitely out there, and it's something I'm thinking more of kind of offering that as a possibility. People find that more appealing.
Mm-hmm. Yeah, totally.
Well, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join us on our Facebook group. The links are on the show notes. Original theme music was composed and performed by Benjamin Kennedy. CME support from Mike here is produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.